Hello, welcome to the LA Institute video series. My name is Dr. Jose Luis Ruiz, and on this video I want to share with you the technique of smile design using the Dento-Facial aesthetic diagnosis system. This will help us make sure that our patients will be happy when we're finished. I'm happy to share with you this very important subject of smile design using the Dento-Facial aesthetic diagnosis system. Now, this is important because, we know that our patients come to our office seeking aesthetic dentistry to improve their smiles. And of course, in their mind, they have an idea what they want to look like. And then it could be maybe they want to look like a movie star, they want a smile that looks like a certain person or certain style, and it's very different. It's very difficult for us to know exactly what's in their mind, because we all understand that aesthetics is subjective. So each one of us have our own preference, and the consequences of not paying attention to our patients' desires is what we see on the screen. This patient, Pat, she came to my office on provisionals, extremely unsatisfied and upset about somebody else who started some porcelain veneers, and she was very unhappy about the provisional. She actually had the permanents made twice, and all of this because the smile design, there was not a proper smile design in advance, and there was not a proper communication between the dentist and the patient. And that's always like that. The bad results are always related to improper communication. So I've developed many years ago, 15 years ago or so, I developed my own system, again called the Dento-Facial aesthetic diagnosis system, using a form and really sitting with the patient and doing co-diagnosis, because again, aesthetics is subjective. We all like different things. We know there's certain aesthetic principles that we need to abide by, but even within those aesthetic principles, there's still variations. There's still a room for preference, and that's why it's so important to sit with the patient, go through the parameters with the patient, understand what the patient's preference is, write it down, and based on that, come out with what the patient would like to have when they're finished. So that's exactly how this system works. So I would like to share with you, the specific steps. This is the purpose of this video. So beauty is subjective, and we don't have absolute rules, but I do want to share with you some important principles. So the questions here would be, when we're looking at the form and we're looking at the patient's face, we're going to start by evaluating if the parameter is within acceptable limits. If we can correct it, we will write down the correction on the form in the section that says ideal. We will write down the procedure, the treatment that will be necessary to get us to where the patient wants to be. If we cannot correct it with our restorative dentistry, then we would need to write down what specialist we may want to seek help from, maybe an orthodontist, maybe a periodontist, so that way we can get the correct alignment of whatever needs to be done in order for us to get our patient satisfied. And if that's the case, then we need to refer the patient out. So basically, those are the principles. And the first thing that we're always going to do is we're going to take a photographic series of the patient's smile, because this Dento-Facial aesthetic diagnosis system is based on photographs. And of course, we don't want to forget the fact that it's not just about photos. We also need to look at the patient when they're talking to us. When we're creating the smile design, we're looking not just at the photos with the patient, but I'm always looking at the patient's face as well. So these are the parameters, and this is the important part to keep in mind. The first parameter is occlusal plane. An occlusal plane is basically We want to see the centrals and the canines are at the same level. If one side is higher than the other, then of course we will have a cant, and cants are not aesthetic. So we would record it on the on the form. Now, if we see that the patient has a cant, then we need to communicate it with the patient. We need to find out if the patient is interested in correcting it. So this is two cases where we see patients that have occlusal cants, and and then if they are seeking any type of aesthetic work, whether it's direct composites or porcelain veneers, or as you can see right here, a bridge. This patient lost, when the patient on the left lost the tooth, she got a bridge, but as you can see, the bridge was made in the wrong occlusal plane, and the patient is very unhappy about the appearance of this bridge. So understand, looking at the occlusal plane is very, very important. The next parameter is midline, and midline is also a very important parameter because if we have a midline that is off to the right or to the left, the patient is not going to have a very symmetrical appearance. Now, the good news about midline is that there's certain things that we do know. We know that if the midline is perpendicular to the occlusal plane, it actually is pretty acceptable, even if the midline is slightly to the right or to the left. Some surveys to patients and dentists have shown that we, the human eye, cannot discern a midline discrepancy that is less than 2 millimeters. Even sometimes 3 millimeters, we will miss it, as long as the midline is perpendicular to the occlusal plane. If the midline is canted, then even if the midline is right in the middle of the face, it's not going to look attractive. So when we correct the midline, we can make some dramatic changes on people's appearances, as you can see right here on the screen. This particular case was done with implant restorations. But as you can see in this photograph, this particular patient has a pretty dramatic midline discrepancy, almost, about 3 millimeters to the right. But when you see her face, you kind of miss that because that midline, again, is perpendicular to the occlusal plane. If it was canted, it would be very undesirable. But because it's perpendicular to the occlusal plane, we almost miss it. And actually, in this particular case, we chose to ignore it, and we chose to restore her teeth, but not correct the midline. And in this particular situation, the midline, if you look at the case in the left, also the case in the right, both midlines are almost in the middle. They're pretty close to the midline, but they both are canted, and you can see how unesthetic that looks. So you see the two extremes. Now, how do we correct those? If we don't use a properly mounted cast that can communicate to the patient, to the laboratory, the amount of cant that you have in the mouth, the laboratory will have a very, very difficult time to predictively correct the midline problem. So that's why it's very, very important when we do our aesthetic cases, we always mount it with a faceable corrected situation. And of course, the Los Angeles Institute, we have our own articulator called the Director, which uses some very, very great tools to allow us to take a very, very good faceable. The one that we see on the screen is another pretty good articulator, the Panadent, which also has the ability to correct for occlusal plane and midline. The next parameter number 3, is facial symmetry. Facial symmetry is very important because when a patient's face is asymmetrical, it can throw us off very, very quickly in regards to occlusal plane, in regards to midline. And one more time, it is incredibly important to have a faceable that allows us to communicate with the laboratory midline discrepancies, occlusal plane discrepancies, because otherwise we will have an incredibly difficult time correcting cases where the patient's face is very asymmetrical. The next parameter is parameter number 4, lip position. And we all understand that the lip is supported by the teeth. So if we orthodontically or even restoratively move the teeth forward 1 or 2 millimeters, there'll be some, some lip variations. And the more we move the lips, the more we move the teeth, the incisal edges of the teeth, the more the change on the lip will be visible. So now we know that there's a big variation in what people prefer nowadays in regards to what an ideal profile looks like versus what used to be in the past. So this is one more time a situation where it's indispensable to communicate with our patients and understand their preference. Some patients which we may see a profile that looks too full, the patient may find it attractive in the other way around. So we want to communicate with the patient if need be to do orthodontics or restoratively and move the incisal edges quite dramatically, then we want to know what the effect of that is going to be on the lip. The next parameter is the facial lower third. And this parameter, as the previous parameter, is evaluated when we're looking at a patient's photograph from the profile. And the facial lower third is also controlled by the teeth. If a patient loses all their teeth, as we understand, the patient's lower facial third will be collapsed dramatically. If the patient loses all their back molars, their facial lower third will be collapsed dramatically. And of course, if patients are bad grinders and clenchers, they can also create some dramatic changes on the lower facial third. If we're planning on doing extensive dentistry, this is something that we could look into, and if we could alter the patient's lower facial third for to improve their appearance. So that's also another important component of this treatment. And you can see an example of this in this photograph, where we see a pretty dramatic change in profile just by adding facial lower, facial lower third. The patient looks younger and more attractive. And again, this is another very, very good example of that. You can see a profile where the patient lower facial third is increased. In this particular case, I did it with restorative dentistry with onlays and veneers, and opened the vertical dimension a good amount. And as you can see, the patient's profile improved pretty dramatically. So we often may choose to open the vertical dimension cases like this, but then of course sometimes closing the vertical dimension may be the preferred choice. So this particular case, this patient had an open vertical dimension, and thus his teeth were huge, and he didn't like the appearance of those teeth. So in his case, we chose to close the vertical dimension by shortening the anterior teeth, and of course we have to do the same thing for the posterior teeth, and that all of that was done with adhesive dentistry. The next parameter is tooth show, and basically what that means is the patient will when they smile, the amount of tooth that they show when they smile is very important. If the incisal edges are close to the lower lip when the patient smiles fully, then the smile looks very, very youthful. When they show very little of the lower teeth, the smile is very youthful. When the patient's incisal edges start getting far away from the lower lip, then they show a lot of lower tooth, and the smile starts looking older and less attractive. So often, especially when we're treating patients who have badly worn out their teeth, often we will consider lengthening the teeth in order to give the patient a more aesthetic smile. And if that's the case, if we find that that's necessary, then as you can see on the form, we can correct the form. We can write on the form the amount of correction that we want to do. Parameter number 7 is the buccal corridor. In a lot of patients, they may have had their wisdom teeth extracted and their bicuspids extracted because of orthodontics. They end up having a very collapsed or narrowed maxillary arch, and then those patients tend to have a pretty dark buccal corridor. And people nowadays want to have a wider smile. They find that to be more attractive. So those type of patients would require that we give them maybe porcelain veneers on the bicuspids to fill the buccal corridor. And when we do that, we can really enhance the appearance. So when we're doing our smile design, we're looking at that specific photograph with a smile, a close-up smile. We can, ask the patient if they're happy with their vocal corridor, if they would like to have a slightly fuller smile, and if that's the case, then the patient will, may choose to do additional veneers or restorations. The next parameter is gingival show, and of course, we want to see a symmetrical amount of gingival show, and usually we would like to see, less than 2 millimeters of gingiva, on females, and on males, usually we don't want to see too much gingiva at all. So when we see too much gingiva, more than 2 millimeters, then then the smile starts looking gummy, and that could be corrected. Of course, if the gingiva is asymmetrical, then that also has a very anesthetic appearance, as you can see on the photograph. So correcting it with possible surgery, crown lengthening surgery, can really make a pretty dramatic change. The next parameter is incisal plane, and also, the assessment of the incisal plane, and compare that to the lip, curvature. And this is important because we understand that some patients have a lip that curves a great deal when they smile, and when that's the case, we want the teeth to follow the same curvature. And we have some patients who have really flat lips that when they smile, they pretty much, their lip don't curve that much. So the incisal edges of the teeth should follow the same type of curvature. Otherwise, we can see what happens in the middle picture. You can see that the teeth have a big curvature, but the lip doesn't. So then the patient looks looks really bucky. So we have to be careful with that when we're making our smile design. We need to understand that and make notations. So when we're done, we will, the patient will have an incisal plane that coincide with the plane or the curvature of the lip. The next parameter is number 11, and we will write down conversational tooth show. Conversational tooth show basically means that we want to see how much tooth shows when the patient is talking. And because people look at our patient's teeth and our patient's mouth when they're smiling and when they're talking. So that's why I personally prefer the conversational tooth show versus the lip at repose. Because when the lip is at repose, then nobody's looking, so it doesn't really matter. When we're talking about aesthetics, what matters is when we're looking, and we're looking when people are talking. And if when we're talking we show no teeth, then that is not aesthetic. So obviously, conversational tooth show, like smile tooth show, changes with age. Younger people, when they talk, they show a lot of teeth. As we get older and we talk, we show less and less tooth. Our lips get longer, our teeth get shorter. So if we see a patient that doesn't show any teeth when they're talking, then that might lead us to make corrections to possibly lengthen those teeth. The next parameters are 12 and 13. 12 and 13 are parameters of axial inclination and rotations. These parameters are going to be evaluated when we look at the retracted smile. And if we see considerable rotations, this should lead us into deciding to do possibly orthodontics. Now, if the patient has rotations, but they have teeth that are very anesthetic already, maybe the shape of the teeth is undesirable, This may also make us make a decision to try to correct rotations and the shape of teeth using porcelain or composite restorations. So this is important. This is when we make that type of decision, when we talk to the patient and get to understand that the patient is willing to go through orthodontics to align first and then restorations later if the shape of the teeth is not going to end up being desirable. So again, this is when we make those decisions, when we're evaluating these parameters. The next parameter is parameter number 14, and we are looking at spacing or crowding. Now, if the patient has a lot of crowding, often that will mean that we need to communicate with the patient that we would want to do the case using orthodontics first, maybe pre-prosthetic ortho. If the patient is unwilling to do that, then we need to make decisions whether the case is actually doable without orthodontics. Uh, of course, the opposite of that would be when the patient has spaces, and if the patient has large spaces and they want us to do the correction restoratively, that can be a challenge sometimes, as you can see on the case, on the lower photograph. You can see that the patient has a large diastema, and she wanted to do this restoratively. So you can imagine that if we don't consolidate those large spaces with ortho, she would end up with very large centrals and large laterals, and she would probably not look very pretty. So cases like this would mean that we need to communicate with the patient the need for orthodontics and see if they're willing to do that. And sometimes if the teeth have the right shape, sometimes orthodontics may be the only treatment that the patient needs. And of course, if the teeth are beat up or unattractive, that the shape of the teeth is inappropriate, then we need to communicate with the patient that the case will be orthodontic, pre-prosthetic ortho, and then restorative. So this is a case where the patient end up having pre-prosthetic ortho and then restorative. This is another example of a patient who, after braces, because she has this conic shaped teeth, after braces, the orthodontist sent it to have restorations. These restorations were done with direct composite. And but independently of what material we're going to use, a smile design is necessary. The next parameter is the embrasures, and this is when we evaluate if the patient has embrasures that are acceptable or if the patient has embrasures that are unacceptable. The next parameter is maxillary or upper anterior incisor inclination. And of course, we all understand that the maxillary anterior teeth need a slight proclination, slight forward inclination. Sometimes straight up and down is also okay, it's acceptable. But when the teeth are inclined too much, of course, the patient is going to look a little bucky, and it's not going to look very pretty. So when we look at a patient from the side view, and all the following parameters are assessed with the smile, profile smile, and also the retracted smile. We can see that the appearance of the following few parameters. We will show this to the patient, and we will communicate with the patient and see if this is something that they're concerned about. And based on that, then we can start also including the correction of this on our treatment plan. Parameter number 17 is aesthetic zone. Aesthetic zone is important because many patients only look at themselves when they are, when they're in the mirror and when they're looking straight on. And if that's the case, sometimes they miss the side view and they might not know how their smile looks from the side. So taking a good side photograph will reveal to the patient information that might be very important in order for us to make a good treatment plan. Many times a side view will lead to a patient saying, "Oh my goodness, I didn't know that tooth looked like that. Could we also include that?" So it's important so we can communicate to the patient and they can understand why we might be suggesting additional teeth. And we don't want the patients to ever think that we're just suggesting as many as possible. We want the patient to see why we are suggesting maybe additional teeth. The next parameter is overjet and overbite, and this parameter one more time will be evaluated with either the side smile or the retracted side teeth. And this is when we evaluate if a patient has the appropriate amount overjet and overbite. This is aesthetically important and functionally, especially functionally, very important. So we want to make sure that we evaluate, we communicate with the patient so we can make the correct, decisions. Parameter number 19 is occlusal plane. And basically it means that when we're looking from the lateral view, we also want to see a either flat, plane. In other words, all the incisal edges from the bicuspids, molars, and anterior teeth should be kind of touching the same flat plane, or possibly the centrals and laterals and canine may be a little longer than the posterior teeth. It is undesirable when we have posterior teeth, they are longer than the anterior teeth. That will be a reverse occlusal plane from a lateral view and is very anesthetic. So as you can see on the screen. And next parameter, and of course that's something that we discuss and communicate with our patient. The next parameter is parameter number 20, and parameter number 20 is papillas. And we need to look at it. We need to assess the shape of the papilla, and we need to make decisions if the patient has a diastema, or maybe if the patient has a gingival embrasure that is open, then we may need to make corrections on it. And we need to, first of all, we need to communicate with the patient and explain the problem and find out if they're willing and desiring to correct it. And if that's the case, then proper communication and proper treatment plan will be necessary. The case on the bottom, as you can see, the patient has the two centrals overlapping one from the other. Now, and even when the centrals are overlapping, you can see already a gingival embrasure that is open, that dark triangle. Now, the patient is here for consultation to possibly have braces or Invisalign to align her teeth. Now, you can imagine that as we align the teeth, that papilla will open up even more. Same thing as in the lower area. So if that's going to be the case, then we need to communicate with the patient. We don't want to, start treatment with this patient and then, later on let the patient, have the patient see that the papilla opened up more, and now they're going to be unhappy. So this is part of our proper smile design, even when we're doing cases like Invisalign. Now, when we have a papilla that is open, we have large gingival embrasures that are open, then also this is an opportunity for us to communicate limitations to the patient. We may want to tell the patient that it's going to be very difficult to fully close those papillas. You can see right here that in this particular case, we made a correction also on a papilla, and we do that by instead of having teeth that are very, very bell shaped, we start making teeth a little more square. It is always good to educate patients about the limitations on closing papillas. The next parameter is gingival symmetry. We understand the centrals, the zenith of the gingiva on the central should be obviously at the same level. Laterals tend to be 1 or 2 millimeters below centrals, and canines tend to be about at the same level as the centrals. But really, that's not a fast rule. There's, again, in aesthetics, there's variety, and there's some patients that may have a pretty straight. All the zeniths are the same in the same place. And of course, what we don't want to have is a very asymmetrical gingival. because it's very anesthetic. And you believe it or not, somebody actually made those crowns, those two centrals, where they completely ignore the gingival symmetry, and the patient was extremely unsatisfied. Gingival Biotype. And this is important whenever we're planning on doing implants, or if we're for any reason we're planning to place margins below the gums and place cord. We need to assess the patient's gingival biotype, because we know that when the biotype is very thin, gingiva is very unpredictable, and it can recede, and if the patient has high expectations of aesthetics, gingival recession could lead to undesirable aesthetic results. So we need to be prepared. We need to evaluate for that. The next parameter is shade, parameter number 23. And of course, shade is probably the number one reason why people will be unhappy with our restorations. It's crazy, but still, shade is the main thing. So I always like to take a current shade. What are the patient present with? And then discuss what would be a desirable shade. And to be honest with you, I think patients, rarely patients are gonna want yellow teeth. So I never really talk about shades there are in, A2 or anything darker than that. Patients always want to have lighter colored teeth, so they're. I like to divide shades, and I really present to patients mostly just two shades. A1, which is natural white, and that's like about as white as it gets on nature. And then B1, which is pretty much a bleach shade, a lightly bleached teeth, and that's usually the whitest that I want to go. I don't want to go too much whiter than B1, because then the patient looks fake and the restorations look unnatural. So rarely do I go a little bit lighter than B1, and yeah, that I might go for like B0.5 or OM2, something like that. But that's very exceptional cases. And of course, some patients are like that. They want super white, and actually, in some patients, it looks good. But the problem is they look fake. A lot of times, you put very white teeth on patients, and maybe the shape is beautiful and everything, but when you see the patient, you know that those are fake. And if that's the case, then we kind of failed. The next parameter is tooth shape, and of course that includes also the embrasures. And when it comes to tooth shape, this is another area where people have different preferences. Some people prefer square teeth. Some people prefer rounder teeth, oval teeth. Some people prefer the centrals to be considerably longer to give them a more youthful appearance. Some people, and of course, there are different actors and actresses. They have different styles of teeth, and that's the beauty of nature. We know that we are a little bit different. So at the LA Institute, we have a pretty cool little smile book that shows different styles of teeth, and it actually shows some actors or artists that may have similar styles of teeth, and so then the patients can make choices on what style of teeth they want to have or shape of teeth do they want to have. This is an optional thing. We don't need to give a patients too many options. We want to give them just a few options. And then finally, parameter number 25. Parameter number 25 is basically the ratio. We know that if the patient smiles and they show the entire tooth and gum, then ratio is very important. We don't want teeth that have the same height and width, because they look square and they look anesthetic, as you can see in the picture on the top. If that's the case, then we need to do something about it. We need to give the patient something that is more ideal, which usually is about, we want, if the tooth is 100% from in the vertical direction, from top to bottom, from incisal edge to gingival area, we want the mesial distal to be about 83% of that, and that gives us an appearance of proper balance. Now, again, aesthetics is subjective, so some people may say 81%, some people may say 79%. It really, it's just an approximation. It doesn't have to be a perfect. What we don't want to have is we don't want to have teeth that are too long, or we don't want to have teeth that are too short. So now that we have, done the 25 parameters, and by the way, if the patient's parameters are within acceptable limits, we just skip it. We don't have to go through all the 25 with every single patient. I would say most of the times when I'm doing my smile design, I will probably touch at about 5 or 6 parameters with each patient. The other ones may be within acceptable limits, or sometimes might be 10, but it never is the 25 parameters that need to be discussed with the patient. So usually I finish my smile design in 5 minutes at the most. After I finish my smile design, I will have made notes, as you see on the screen. You can see some marks. I will have made notes that depict the parameters that are not acceptable to myself and to the patient. Usually on the top part, you see 4 lines. Those are the 4 primary concerns of the patient, and we write them down so that way we understand what does the patient really want. What are the most important things? There might be 10 parameters that are not acceptable, but there's a few things that we know the patient really, really, really wants, and we want to make sure that we can give the patient that. So with that information, then we write a lab slip. So the laboratory will have the information that they need in order to develop a wax up that really fulfills the patient's wants. We should never send a model or a cast of a patient without a proper instructions to the laboratory. We want the teeth to be this much longer. We want the incisal edges to be this much out or this much in. Otherwise, if we don't communicate that information to the laboratory is just going to guesstimate. And the results are never going to be as desirable. So proper communication to the laboratory, then the laboratory will give us a corrected occlusal plane, corrected midline. Granted, these wax ups are now very pretty. The laboratory that I used in this particular case was not the highest end laboratory, so you can see that. Nevertheless, you can see that by communicating to the laboratory, we can get corrections, difficult corrections like occlusal plane correction, midline correction, especially when we give the laboratory a properly mounted cast. So with that information, you see, slightly better wax ups right there on the top. The wax ups have been developed to fulfill the patient's goals. You see how the pre-op on the bottom. You see the wax ups on the top. We will use the wax ups to fabricate provisionals, and by doing so, we can show our patients excellent results. Again, properly mounted cast mix is super important, especially when patients have a lot of asymmetry, as you can see in this particular picture. The patient has a huge occlusal cant, a midline that is canted. So in this particular case, we end up needing to do gingivectomies to do corrections, but we can give our patient pretty good results after all of that. So with all of that information, we can create proper wax ups. The wax ups are going to be used to fabricate provisionals after minimal invasive supragingival preparations, and that will lead to predictable results. So I want to thank you very much for your time, and I'll see you next time.